Welcome to another episode of Dueling Perspective. I'm your host, Dr. Diana Shechtman. Today's Dueling is all about the world of myopia, and we want to thank Cooper Vision for the distribution of MiSight. It is definitely the most interested choice when it comes to soft contact lenses in the treatment of myopia management. People said if we are proactive, we focus on preparation, and yet when we're reactive, we're focusing on repairing. Jeff, I know you've obviously put a lot of this stuff in many of your lectures before. So, do you want to kind of assess to that before I introduce you, Dr. Jeff Gerson?
Yeah, I mean, like you said, Dana, we've done a bunch of talks together where really what we focus on is being proactive instead of reactive. And in any type of ocular pathology situation, that it's much easier to get out in front of something than it is to try to get out from behind it. And so I think that's kind of what we're going to be talking about today, getting in front of myopia and the roles that we can play instead of just being purely reactive.
Jeff, honestly, you are one of the best well known KOLs out there. You have a plethora of lectures, both national and international. I know you do a wide span medical optometry at Grin Eye Care in Kansas. And honestly, we can probably do a whole podcast regarding the lectures that we have done and share at the podium time, but that's a whole different story right there. I also have the pleasure of introducing Brianna Rhue. She was one of my previous students and one of the most amazing go-getters. And I knew that from the get-go, Brianna, when you were side by side with me doing a cycling class, 6 months pregnant, you thought you were just going to beat me. And sadly enough, you did. So I knew you were way ahead of your times. As a leader in the area of myopia control, you're also an author, and it was a really impressive book, The Eye Pitch, as well as you are the founder of Dr. Contacts, which I think is somewhere in that office of yours, and the owner of West Broward Eye Care. It's amazing. You do it all, and you do it with a smile. So, welcome to you both.
Thank you for having me.
Thank you.
Rue, let me start with you. Jeff, you and I have been here long enough in our careers where when we went to school, there was really no essence in regards to a myopia management class. So, I mean, as far as I remember, there wasn't anything but refractive error. The disease in it of itself wasn't really considered a disease. So let me turn it back to Rue. Rue, do you actually think this has changed?
Been looking back at my notes too. So graduating in 2009, we were still taught it was a refractive error, but in other parts of the world, MiSight was already available, right? So in Australia and New Zealand, that was already in practice when I graduated. And if you fast forward to now the NASEM report, which is now going to just be a year old in November, then it has changed. So that's Congress putting big money behind it, and it has now gotten the disease designation, which is exactly what it is. Soft tissue, bony orbit, growing abnormally, leading to issues. That's the definition of a disease.
I think Jeff and I have seen quite a bit, even the medical lectures nowadays have aspects of myopia management within the symposium. Have you not, Jeff?
Yeah, for a long time, I've kind of joked about anti-VEGF injections that they're for anything retina other than myopia, that they didn't fix myopia. But the reality is one of the most potential problematic things of myopia actually can be fixed by anti-VEGF.
That's
And
interesting.
so one of the complications. So yeah, I mean, I think absolutely it's shifted to where it's hard to really do a talk about pathology and talk about the retinal treatments if you're not going to at least bring up to some respect what could happen due to myopia.
So, Jeff, in regards to that, and you're talking about anti-VEGFs and the eye in and of itself, let's start with a scenario. 33-year-old white female comes in for an evaluation of her high myopia. Let's make her a 9 diopter myope. She's got her child with her, maybe they're 7, 8, or 9, and they're embedded in their iPhone while you're conducting the exam. Take me through the exam of this patient. What tests would you do? What are you looking for in regards to complications from the periphery all the way to the macula?
Yeah, so I would say I don't know that I actually do my exam any differently. It's just what I'm looking for is going to be a little bit different. So, if you say she's a -9, then we know she's more than 20 times as likely as someone that's not myopic to have a retinal detachment, over 100 times more likely to have myopic maculopathy. We know she's at greater risk for glaucoma. We know she's at greater risk for cataract. So it's just all these things that we're normally looking for that maybe we're going to look a little bit harder, even at a younger age, because of the extreme increase in risk. But what I would tell you is, in the mom's case, her story's already been hasn't been completely written yet, obviously, but you're way past the introduction. But with her child, you're still at the introduction of the story. And so, I mean, to be quite honest, even with the mom as my patient, the focus is going to at least at some point turn to the child. And number one, has your child had an eye exam, a real eye exam by an eye care professional, not just a pediatrician or a school screening? And if no, then obviously that kind of shifts priority to what can be done for the child and not just the mom. Because again, anything you do for the mom is reactive. Anything you can do for the child is being proactive.
So let's bring that's a great way of looking at it. So let's bring it up to Brianna. Brianna, patient comes to you, Jeff refers the patient to you. How do you start the conversation first with mom there, especially being a 9 diopter myope? How's the conversation in regards to the benefits as well as the risk for this child?
So are we examining the mom or the kid at this point? So is he
We're
referred the
examining,
kid
Jeff
over?
did a great job with mom, so you don't have to worry about mom. I mean, you know that Jeff's telling you, Jeff referred you the patient, letting you know mom's a 9 diopter myope already.
Yeah.
And let's say you are refracting the child and the child is 1 diopter myope and they're 6 or 7, which is already, exactly, it's already started the process. So how do you have the conversation with mom?
Yeah, so actually these conversations are way easier. I would love all the conversations to go this way. But the mom already knows where her child could potentially be headed. And we're going to do a refraction. We're going to look at K readings. We're going to look at axial length to determine how aggressive we need to be with treatment. I'm using something now called Ocumetra, which is a calculator. So it's looking at everything and telling me how aggressive I need to be. So it's just one big myopia equation that you get to put together. And if you're not measuring axial length, you can still do it. It's just algebra. If you have refraction and you have K readings, there's some calculators that you can now actually see axial length. So let's say that's a -1 at 6 years old with a 43 Ks and axial length is already 24.5. That's probably where that kid would be measuring. She's going to be projected to be worse than her mom. So that's a pretty easy onboarding system with that kid. And then now we're directly talking. When I do axial length, I'm actually measuring it with a DGH scanner. I have about a couple in my office, actually. Just nerd out on this stuff a little bit too much. But
I can see that.
the scanner that I do is it's actually contact. And so what I'm looking at is not just the patient data, like K readings, refraction, axial length, mom and dad myopia, mirror time, outdoor time, but actually how the patient is interacting. Is the mom hovering? Is the dad hovering? Is the kid sitting still? Could they be a good contact lens wearer? So if I can get that measurement, we're talking about contacts, 6, 7, 8 years old. And we're putting them on that day.
In that day. So do you usually, is your go-to usually contacts? Talk to me about your go-to, which companies you use and why, any major benefits, because there's different options out there and you just mentioned the contact lens related ones.
Yeah, so you have atropine, low dose atropine is great. It's kind of my gateway drug, right? So my 4, 5, 6 year olds that I can't get into a contact lens option, it's a great starting point. And I'm even prophylacting, like if Jeff had referred that kid and they're plus 50 at 6, 7, or 8, with mom being a -9, probably dad's maybe a little myopic themselves, probably not as bad as mom, then we're even maybe prophylactically treating, again, being proactive, because I want to catch it. Every year I can delay the onset of myopia, it all adds up on the back end. So again, if the kid is sitting still, and it was funny, I was hearing another speaker talk, and he does the shoe tying method. Like if the kid can tie their shoes, they can do contacts. Well, I will tell you, and I'm mom guilt right here. My 8-year-old, there's not shoes that people tie anymore. Like our 7, 8, and 9-year-olds can't tie their shoes, guys. Like mom guilt right here. I'm like, no, that's not like a titration level to see if they're ready for contacts, if they can tie their shoes. Because like literally, there's no shoes to buy with tie. So mine is just like, can the kids sit still? Are they motivated? And I know if I can get just one in, like they'll do it. So you have MiSight, you have Ortho-K. For those higher levels, you have Natural View Multifocal, which is off-label, getting into your Biofinity toric multifocals if you need. Spectacles obviously aren't here yet. They're coming soon. And so I think when spectacles and atropine are going to be a good combo therapy. But it's all about how aggressive I need to be.
Hey, Bree, when you say motivation, are you talking about the parents' motivation or the kids' motivation? Because what I have
Both.
seen,
Mine is both.
yeah, because what I've seen and the way that I approach it is right or wrong. I don't care as much about the kids' motivation because hopefully, especially in a 7, 8, 9 year old, I understand motivation is important, but if you don't have the parents on board, you can't get the kid.
Correct.
And if you have the parent on board, then usually you can get the kid on board. Because
Yeah. And
to these younger kids that have never worn glasses or contacts, they're not very motivated for either,
correct.
and they need something. And so why not make it what's going to ultimately be best for them in the long run?
Yeah, getting the parents on board, I found, is actually pretty easy. So my whole thing is I don't present any options unless I have both parents present. So I try to get both parents, whether it's FaceTime, on board together to also understand the family unit. So are they living at mom's and they're living at dad's? Are they living together? Who makes the decisions? Who's going to be the driving force? And she would not let me touch her, like at all. But I knew if I could get just one in, that it would change her life, right? So a lot of doctors were too rigid, where your kid's not leaving here until they can put them in and out 5 times. That's not what I did. I know mom wears contacts. I know brother wears contacts. I gave them the trials, the diagnostic lenses to go home. She came back a week later, a different kid. And guess who got the contacts in? It was her brother. Her brother got her contacts in. So that's something that they're going to get to share for a very long time. And now she's been stable. But it's just about the family unit, like you said, Jeff.
Jeff, you don't do any myopia management, correct? You pretty
No,
much
I actually do.
you
Yeah, I
do.
actually do. Yeah, I do because I mean, we see all ages in our practice, and so I do have kids that I've used my sight on, and a couple that I'm using atropine with.
Why do you choose MiSight over all the other options that Brianna had mentioned?
Yeah, for me, I think it's 2 reasons. One, it's really easy. And when I say easy, it's easy for me and it's easy for the patient. So I mean, it is very easy, low maintenance, and especially when you're talking about 9, 10, 11-year-old kids, I think it's important to simplify the regimen of what you're going to do as much as possible. So that's the main reason why I'm using my site, and because we know that it works. Like Brianna said, it's relatively new to us, but it's not new. And so there's tons of data that tells us what we can expect, that makes it super easy to talk to the parents and look, this is what we can expect from this. So for me, it's about simplicity.
And how long, when do you make the decision to stop? Like it's enough. Do you wait for a certain age group? Do you wait for a certain level to level out? Like how do you make that decision?
Yeah, it's a good question. So I haven't had to do that yet because I've been
Just started
using
the
my
first one last week.
no, 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 no. But I mean, I've been using my site for probably 2 years now.
Okay.
And, when you start with kids that are 8, 9, 10, 12, 13, and and it's only been 2 years, it's too soon. I think it's too soon to stop. And, I think kind of like what Brianna was saying before about, really the way that she painted the picture of what do you decide on doing, you've got a puzzle. and you get as many pieces of the puzzle as you can to figure out what the picture is to know what to do. And I think the when do you stop is a similar picture, right? To me, at least, it's not, and again, I haven't had to come up with the answer to this yet, but when I do have to come up with that, it's not going to be just one thing like, oh, you turned 18, we're going to stop. Or, oh, you've been stable for 1 year, we're going to stop. I think there's likely a number of factors that go into it, and it's going to be somewhat individualized. Like if someone's 30 years old, they don't need to still be doing myopia control. I think that's probably beyond. But I think there's plenty of gray area, right? If they're 7 or 8, you keep going. If they're 30, you stop. In between there, I think is where it takes some. It's the art of what we do and some finesse to it.
You know what I thought about it, and this is just kind of a little bit on the side. You mentioned the 30 and the 7 and 8 year old, but say your old patient that we just mentioned before, she was 30 years old. Let's say you did find a choroidal neovascular membrane or some sort of maculopathy at hand that needed treatment. If that child, and particularly not necessarily a 7 or 8 year old, but say a 10 year old or a 12 year old, would see their mother go through injections, for example, or a surgery with regards to a retinal detachment, that could be incredibly impactful. To state, like, if I'm on the track of being that highly myopic and having those complications, it becomes a fear factor where the patient may stick to, because I am sure, Brianna, you probably see this a lot more. You've been doing this a long time. The patients may be compliant for a long time, but then it's kind of like, okay, I've done it already. I've done it enough. It's enough for me. They're not getting that satisfaction anymore. Um, do you continue? Like, how do you? I'm sure you get these challenges all the time.
Mhm.
And using that fear factor may be impactful to some degree for those particular ones, but what do you do with those challenges?
Yeah, so I think it's important that you're honest up front when you're starting a treatment that this is going to be for a long time. And it could be 18, 22, 23, right? And so that's where the Cooper Vision lenses, some of us are doing is seeing where they are at 18, 19, 20, stop the lenses, and maybe you go to a MyDay Energis, right? Where it has that little bump in the bottom. And you really are talking about the outdoor time, right? Everybody's like, touch grass. That's a thing now. Like people are prescribing to go touch grass, which I think I'm going to start prescribing now. Like go sit under a tree uh, with not your device. So that longevity, even if you not sell, I said a bad word to optometrists. Sorry, guys. If you prescribe a MiSight to the patient, even if they do it for just 1 year, you've changed the endpoint substantially, which is so cool, right? And this is also just near and dear to my heart. Why I love this so much. I'm a -5.5. So Jeff, you've seen some of the pictures, and Diana too. It's a soft tissue bony orbit. It has nowhere to go. That's why you get kinked optic nerves. That's why you get bad double vision. That's why the stretching that you see, the tilted discs. And so think of it like a fitted bed sheet. The retina is like a fitted bed sheet. When you pull the retina, a retinal detachment or retinal tear, like my mom had, that's just the corner popping off. Hopefully, macula's on, we get them treated, and quickly we can obviously save vision. If it's that stretching, those micro tears, that's what you're preventing. So that's why the every diopter matters. But I'm also, again, how aggressive do you need to be? That's where these calculators are becoming really critical to get the parents on board.
Well,
Brie, I was going to say something real quick. You said, determining how aggressive you need to be, but
Yeah.
I don't know the answer to this, but I would imagine that majority of optometrists, ophthalmologists that are doing routine eye care are not routinely talking about or prescribing myopia control. And so to me, and which is why I started doing it, even though that's not like my thing, my thing within our practice. I'm not the peds one. I stay away from the kids, right? But when I have kids and they're myopic, then this is something that's important. But I think that it's not just a matter of how aggressive do you need to be. The real answer is you need to be more aggressive than do nothing. And I think that's really step one. And the other thing I would say is that, you obviously do a lot of this, and for people that don't, number one, it's not that hard. to incorporate into your practice. Like it's
No.
not that hard. I can do it, right? But even if you think it's too hard or you don't want to do it, find someone that does.
That's
Just
key.
like if you're an optometrist, you're not doing cataract surgery, but you have patients that need it. So you
Exactly.
find someone that does it, and what you probably then do is you find someone that does it well, and that's who you share your patients with. So I think that's, to me, more important than how aggressive do you need to be is realize that you need to do something.
Being
And thinking about it this way, Jeff, because I do obviously a lot of lecturing, and people will come up, and you've been in these lectures where it's like,
Yeah,
guys, how many people are doing this? And 6 hands go up,
yeah,
right where we were together. I was
yeah.
like, oh God.
It was
And then
shocking.
my lecture is all about like how to do it, not like here's MiSight, here's North. And so like I got some reviews on that lecture that were pretty interesting, Jeff. Neither here nor there, but it was a really good lecture. I thought it was. You can
As long as
probably
you thought it was
say
good.
the difference. Yeah, I gave you 5 stars. But it's not up to you. It's not up to you to decide if it's up to the parents to decide if they want myopia to mean something to them or not. It's up to you to present the science, which we have, and the options, and help them down a path that it is important. So I don't use the scare tactics because I don't want mommy guilt. I don't need any more mommy guilt or daddy guilt, right? And that's the piece to this that's all missing is, so you're just telling me you see glaucoma and you're not going to prescribe a glaucoma drop? Or you see a patient with meibomian gland dysfunction, you're not going to be talking about dry eye disease and where that's headed? Or you see a patient with a PSC cataract and you're not going to discuss it? So why are we not discussing something that we know we can slow down? That's malpractice at this point.
Yeah, but to me, it's not just the slow it down, right? Because if you just say if that's all someone understands of it, they
Yeah,
see it as like a cosmetic thing. Oh, so you're saying that I won't just need a stick of glasses. But when you say, the science of it, I think there's two sides of the science, right? One side of it is what can we do to slow the progression of myopia?
yeah,
And the other side of the science is what can we do to decrease your risk of the complications of myopia?
correct.
That's what I think.
And I think it's got to be
It
both
is
of
both.
those.
Yeah,
Yeah.
yeah. So I have a little bit of both in there, but I don't, again, there's 7, 8, so I just got to get them on board to
Yeah.
do it. Um, and that's where it all meshes with how aggressive do you need to be, but it's up to you to present it. Because I'm
Yeah, for
seeing now
sure.
kids referred in that are 8, that are already -3. You know they're going to be worse next year, man. So even if you're not doing it, why are we saying I'll see you back in a year, knowing it's going to be worse? Just start there. See you back in 6 months and
100%.
prescribe outdoor time.
Yeah.
You
That's
guys,
easy for anybody.
you guys gave me a lot to think about here. And I'm not going to be starting MiSight or any kind of myopia management anytime soon. But at
Do
the
you
end of the
see
day,
anybody under the age of like 50?
I I do
Oh, okay.
occasionally, and I do see younger people. But the end all, we don't even have a phoropter in our office. But I do see a lot of the patients, unfortunately, who are those young patients who had a choroidal neovascular membrane, and they're there every month getting injected. Thankfully, when it comes to myopic, and I know you know this, Jeff, when it comes to choroidal neovascular membranes associated with myopia, it does kind of stop. It's not going to be a continuous injection like it is with wet AMD. But it is hard. All these young people with retinal detachments, and believe you me, they're not even aware about their children and their risk. Oftentimes, they are not. So when you present that to them, just like Jeff integrated both entities, not only from the progression slowing down, but they can potentially be the you, it becomes a huge impact. And it's a much easier conversation for Brianna to have. And those are the individuals who will probably tell others and their friends
Yeah.
and their families about, oh my God, the success story when they're at the park with the kids or the mommy and me classes. But I'll give you guys kind of a wrap up few minutes because I do want to appreciate your time. Brianna, we'll start with ladies first. So give me quick story, quick tip, anything you want them to take from this particular podcast. What do you got for me?
Yeah, I think it's just, whoa, hold on. I haven't
Ooh,
moved.
lights out.
Oh.
Okay, Brianna's done.
Lights out. Just done.
Time's
just
up.
Mic drop. Not even saying anything.
That was it. She dropped the mic. She's out. That's great, Brianna.
It really is just to start. And if this is not your passion, find something. Number one, find your niche. So and you're taking care of a community. So as a private practitioner in a family practice, you're going to have moms, dads, dry eye, myopia management, scleral lenses. This doesn't have to be a specialty. So MiSight, if you're already fitting kids in contacts, which you should, because that's what changed my life, that's actually, say I became an optometrist in second grade when I got my first pair of glasses. Was already a minus 250, so that was a fun conversation. And my mom begged my optometrist to put me in contacts, and he was hesitant, but I was a dancer, I was a gymnast, I was bouncing off the walls. And so contacts gave me confidence, because kids are mean, right? But you're going to have kids that want to wear glasses, and you're going to have kids that want to wear contacts, and you have to be that advocate for the kid in their dailies. Put them in, throw them out. If you're already fitting single vision lenses, you can do this hands down. It's so simple. So just start. Just seeing your art, you can already figure out what axial length is. And lectures like this, just find some education and bounce ideas off of people.
That's great. Jeff, I mean, you're going to be paired up against Brianna, but any parting words? Usually you got a good little quote, statement, story. What you
I
got?
already had a few. I
know,
had a
that
few.
was the last one. I want them to leave. Like if they left
Yeah.
this is what Jeff Gerson told me at the podcast. And this
Jeff is doing myopia management. Anyway.
Well, that's just it, honestly. So honestly, what I would say is it's not that hard. I mean, really, all you got to do is pay a little bit of attention. And my way of doing things is I'm not big on long monologues in the exam room of me giving explanations of things. For me, everything's about a one-liner, right? And so a lot of times I'll look back at the mom or the dad and I see that, they're 6, 7 diopter myope by looking at their glasses, or know that they wear contacts. They're a patient of mine, and just figure out how to put it in 1 or 2 lines. Hey, because of how nearsighted you are, your child's becoming nearsighted, and we know we can reduce the risk of them becoming more nearsighted or complications from it by using specific contacts. Like that's about maybe it's 1.5 lines. And if it's then I can do that for you, or if it's let me send you to Dr. Rhue to do it, it doesn't matter. Start with your 1 or 2 lines, get them in the right hands, and move forward. I like what Brianna said though about prescribing, touching grass, because it's an interesting concept that none of this has to be hard, right? Like fitting contacts, it's what we all do. It's not hard. Telling someone to spend more time outside or a little bit less time on devices, it's not hard. It's just a matter of just take a little bit of initiative. It doesn't take much time. And Bri, I love how you pointed out just how much of a difference you can make, even if you only get them to do it for a year and they don't come back. You've done good. And so so I guess that's my parting thought or message is it's not that hard, because Jeff Gerson can do it. It's not that hard.
I'm a little scared with this last message. We'll go.
Yeah. No,
we certainly don't need to be specialists, just like Jeff had mentioned, especially in the world of myopia control, and especially when we have people like Brianna Rhue who do such an amazing job. But being proactive is definitely important, bringing back to what we had stated initially. I want to thank you both. You guys are just incredible. I almost miss being part of the podiums with you two here. But I'm 2027, Jeff. I'll be in Kansas.
All right.
I want to also thank our host, Fluorescene Media. If you guys like this, please subscribe. And that's a wrap. We look forward to the next one at hand. Thank you so much.
Thank you.
Thanks, Diane.